Good afternoon and welcome to today's AFTD Healthcare Professional Webinar, Supporting FTD Care Partners with Individual Therapy, Approaches and Key Considerations. My name is Ann Schoonover and I am a helpline specialist at the Association for Frontotemporal Degeneration. Thank you for joining us today. We are pleased to present today's webinar, designed to educate mental health professionals about FTD care. Caring for a family member with FTD can profoundly impact one's emotional and mental well-being. Care partners are often encouraged to seek support, including by seeking individual therapy. But finding a therapist who truly understands FTD's distinct challenges can be a struggle. Today's webinar is intended to be a resource to provide education on the role of therapy to support FTD care partners. We will get to the webinar presentation shortly. Just a few quick announcements. First, you should know that we have muted our audience to limit background noise. AFTD staff are working behind the scenes, so if you encounter a technical issue, let us know directly by writing a message in the Q&A box. Second, time permitting, we will conduct a brief Q&A session at the end of the webinar. Use the same Q&A box to submit a question. If you want to submit a question anonymously, just click the box to the left of the send button. We will try to answer as many as we can. You don't have to wait until the end of the webinar. You can submit your question at any time. Also, this webinar will be recorded and archived for later viewing on AFTD's YouTube page and in the webinar section of our website. AFTD's website includes an entire section with FTD-specific information for healthcare professionals. This includes our entire archive of healthcare professional webinars, as well as a library of the issues of our e-publication, Partners in FTD Care, which details best practices and other information to support your work with families. New issues come out every other month. You can get them delivered by email by joining our mailing list. The FTD Disorders Registry is a powerful tool in the movement to advance the science, discover treatments, and a cure for FTD. We encourage anyone with a connection to FTD and an interest in research to join the registry and help change the course of these disorders. Participants can share their lived experience and remain informed of FTD research opportunities. Visit ftdregistry.org to learn more. For healthcare professionals watching today's webinar live, we're offering continuing education credit via Rush University. This is part of AFTD's efforts to educate healthcare professionals on FTD and FTD care. Tomorrow, you will receive an email explaining how to apply for your credit. Be sure to check your spam folder. You have 10 days from the date of this activity to complete the evaluation and claim credit. Additionally, you'll receive a follow-up email next week with the recording of today's presentation and other related materials. For today's webinar, we have 3 learning objectives. Recognize the unique challenges of the FTD caregiving journey, which can differ greatly from other forms of dementia caregiving. Describe the role of individual therapy in providing support for FTD care partners. Identify supportive approaches and strategies for individual therapy with FTD care partners. Now, I'd like to introduce our guest presenter. Stephanie Muskat is an award-winning registered social worker and and the founder of Compassion in Caregiving. Prior to transitioning to private practice full-time, Stephanie worked in acute care and mental health research at several major hospitals in the Greater Toronto area. Her work is primarily focused on caregivers and their loved ones. Stephanie has been featured on numerous television networks and radio stations and has presented at universities to raise awareness about mental health and mental health support. Stephanie has acted as a primary caregiver to several family members and brings her personal experiences to her work with clients. We're grateful to Stephanie for sharing her expertise and insights with us today. Please join me in giving a warm welcome to Stephanie Muskat.
Thank you so much, Anne. I'm going to share my screen now. Okay. So today we have a really exciting presentation. I feel, because we're going to be talking about supporting FTD care partners with individual therapy. And as I go through today's presentation, you will see that the importance of individual therapy cannot be overstated. I think that, as Anne said, I have my own personal experiences caring for family members, one of which was my mom with FTD, which I'll talk about a little later on. And the fact that we have more awareness now about what's needed is amazing. So thank you for being here today. It's a true honor. So just on this slide, I do not have anything to disclose or any conflicts of interest. And before starting the presentation, again, Anne very nicely introduced me. Thank you, Anne. Just to take it into more detail, FTD to me is very near and dear to my heart. I cared for my mom who had FTD, and very early on, I saw that there were not mental health supports available that I truly needed as I was going through my own experiences. And so many years later, decided to use that to actually fuel my career. I became a social worker. I worked in hospital, and I continued to see that the gaps that were present for me were present for a lot of the clients I was working with who were caregivers and the people they cared for. What was also pretty obvious to me is that FTD had a lot of nuances that were different than caregivers caring for other dementias, such as Alzheimer's, and the support that was needed was very different as well. So I started my company for caregivers to support their mental health in 2021. And it really just started out as something that was supposed to validate people's experiences and share anonymous caregiver stories. And since then, it's become so much more. I'm so honored to do the work that I do and work with caregivers and the people that they care for and healthcare providers all around the world. We not only have a mental health private practice here in Toronto, Canada, which is where I'm at, and in Ontario and Alberta, but now we also offer coaching worldwide. And we also do a lot of advocacy. We run webinars and workshops like this one. We also have an Instagram page where you can see more about us, what we do. We share tips and resources. And it's at Compassion and Caregiving, which you can see. And I have a podcast because I always try to complement our paid for services with anything that we can provide free of charge as a resource. And so it's called Caregivers Compass. It's available across all platforms. And we talk a lot about caregiving. I share my experience going through the FTD journey. And this season specifically is quite FTD heavy. We've had so many guests talk about FTD this season. I'm so grateful they've come on because my mom actually passed away this year. And so each season goes along with where I'm at. So as I said, very thankful to be here, and we're going to hop right into the webinar. Okay, so a lot of the common FTD caregiver concerns can overlap general caregiver concerns, but I am going to highlight what the differences are as we move along and different therapeutic approaches that we can use to target these concerns. So a lot of what we might hear in practice, and this is across the board, whether you're doing ongoing psychotherapy, whether you're doing brief solution focused therapy, whether it's just a few interactions in a clinic or a hospital, we see a lot of different types of grief. We see burnout, anxiety, overwhelm, sleep disturbances, guilt, and shame. That one is a big one. And today I'm going to highlight not all of these because I think based off of a lot of the training and what we learn as mental health clinicians, we are pretty well equipped, I would say, from the get-go, at least I was, and a lot of my colleagues were, to identify and deal with anxiety. But we are not as equipped to deal with the other elements, and so that's what I'm going to mainly focus on today. We're starting with grief because to me, grief is really important in identifying for our clients, and it's not something that our community as a whole has a grasp on. When I see clients come through the door and I start to provide education on grief, I met with confusion because our society tends to focus as grief just as something that happens when you lose someone due to death. But the truth is that all throughout frontotemporal degeneration or other sorts of declining illnesses, grief is present. But most of the people we work with or see do not know that it's present. And I would say I went through that too. I had no idea that I was grieving when I was grieving. So, a big element of grief, just to start, is once we've started working with the person, we've met them where they're at, we are going to start identifying and educating what the different types of grief are. It's like a light bulb moment for clients when they realize, oh my gosh, I have been grieving this entire time. And also naming that grief doesn't just end, right? And it's an ongoing process. I think it's also difficult when it comes to an FTD or other degenerative illnesses because grief takes different forms. It shows up in different ways all throughout an illness, and it doesn't really have a lot of closure. It's just once you kind of think you've dealt with it, it presents itself in a different way. So I try to identify the different ways that grief present, and the common griefs we might talk about or at least think about are anticipatory grief. So anticipating what might come in the future and feeling grief over a change in an illness or even an upcoming loss or death. We might be talking about ambiguous grief. So grief that we can't necessarily name, but we know it's coming up. And this can present with different life stages, like if somebody who is caring for someone with a frontotemporal degeneration might be going through, a university career, they're having a child, and they would expect that their parent is going through it with them. They can feel ambiguous grief or ambiguous loss as they go through those stages. And there's many other forms of grief, but those are the main types of grief that I would name for my clients. And then we do have grief after loss. And a lot of times in ongoing therapy, I'm not only going through the grief with the client as they're going through the illness, but also as they've lost the person. And so naming that as well is really, really helpful. FTD is not straightforward. And I think that a lot of times people outside the home initially do not realize the changes that are going on inside the home. We hear a lot that when FTD comes on, even before diagnosis, it's usually the person living with them or the caregiver is noticing changes before everybody else is noticing changes. And this can bring up a lot of grief and confusion as well, because why do I feel loss and why do I feel change, but yet nobody else seems to be feeling this loss and change? And this can further add elements of isolation and overwhelm in addition to managing the situation. So when it comes to grief, once we've validated an experience and once we've provided education on you can experience grief very much so all throughout an illness or a diagnosis, especially with FTD, I might hear from my client, this is too much. I can't handle it. It's too painful. It's like a stab in my heart. I don't want to deal with this. What we know from the grief research and grief literature is that in the grieving experience, and a lot of literature is after death, but we are applying this to the grief process as well, all throughout FTD, is that when someone pushes down grief, it doesn't just go away. It comes out in other ways or it shows itself, and we can't just ignore it. And so at this point, a modality that I really, really like, I use it in my practice often across all platforms with caregivers, is acceptance and commitment therapy. Because we can't necessarily challenge grief, right? But what we can do is make space and awareness for the emotion. And the reason I really like acceptance and commitment therapy is because it's an approach where we're learning that we can't control the thoughts and feelings that are coming in. Our body actually is made to feel these things. And so instead of pushing these things away, even when they feel scary, can we make space for them and employ grounding techniques, anchoring techniques, and really making it so that the emotion is identified as an emotion, as a thought, and we learn to process it in that way with self-compassion, with elements of mindfulness. It does really well and it completely changes how people approach and see emotions. But yeah, grief is really, really painful. And so we're also making space for grief in our work with our clients. And that's why I highly recommend getting trained or doing some training in grief focused therapy, because I don't think I've ever seen someone go through an FTD without feeling grief. And the grief changes over time. Today, I'll be talking a lot about the behavioral variant FTD because there are a lot of nuances involved with the behavioral form of FTD in comparison to other dementias and illnesses. But it's really important that people start to see that they can actually process grief, and we're making it a safe space for people to process grief. So if you're looking at ways to get trained or what you can focus on, getting grief training and ACT training, there's also ACT training in grief and loss, which I've done too, are really important approaches. So I talked about this a little bit earlier on, but confusion when it comes to the presentation of an illness versus insight, and what that can do for a person in regards to grief, and what it can do for a person in terms of other aspects of shame and guilt. So I'll paint a picture for you of how this typically presents and what I mean. So early on in FTD, and even sometimes ongoing, regardless of the presentation, whether it's PPA or BVFTD, there can be a perception by the person who's caring or the person who's living with this person that something is going on before other people in the external environment might notice it. There's something called masking, and there's also other reasons why this happens. But essentially, usually, behaviors are attributed to the person at home before other people can see it. And as we know, it can take many years to get a diagnosis. And so the caregiver or the person living with this other person might start to say, I feel like something is off. But when they're asking other people, friends and family who might live outside of the home or people that have observed this person, they might be getting feedback that no, I don't see it. I mean, the person is working, everything is normal. I don't know what you're noticing. And it leads to the caregiver to start questioning their own self. They start thinking that maybe something is wrong with them. They start thinking that maybe they're getting an illness. They start questioning everything they know to be true. It can lead to exacerbation and elements of shame and guilt, because if they're also getting told by this person who has a BVFTD, for example, that they're the issue, which again, we do see a lot with behavioral variant FTD, they're starting to think maybe I am the issue. But yet they're also grieving this relationship that they had. They're grieving what they know to be true with this person, and nobody else is meeting them where they're at. So a big part of our involvement, especially in the early stages and even later on, is being a validator for the person who is caring, our client who is coming to us saying, nobody else believes me. I feel crazy. I feel alone. There's so much isolation and loneliness throughout this diagnosis as a caregiver, and this just heightens it. And our role is not to provide a diagnosis. It's not to validate, what I see and therefore it must mean it's this sort of FTD. It's to validate that what our client feels is true and that we believe them and we're in this space with them. We know that the therapeutic alliance is the #1 predictor of client success over time in therapy. And that is a very big part of this. Are we having a safe space? Is this a place where when no one else understands this person outside of our sessions or outside of when we're meeting them in the hospital or the appointment, are we that safe space for them that, oh my gosh, I can breathe a sigh of relief because even though nobody else understands me, you do, right? You understand my grief, you understand my isolation, and you understand, and I have somebody else who can be through this with me. So I want to name that with FTD because with an Alzheimer's, for example, it's more common for other people to see the memory loss at the same time, but FTD can present differently. So let's talk about behaviors. I said before that I was going to be talking about behaviors quite a bit. And the reason that I talk about this is, again, it is a very big differentiator compared to other sorts of degenerative illnesses. We see behaviors in some other illnesses, including anoxic brain injuries, traumatic brain injuries, and stroke. But when it comes to a dementia, there is a feeling that nobody understands the caregiver because when they might communicate to somebody, oh, yes, the person I care for has a degenerative brain diagnosis, they're having behaviors. Now, This is a really hard one because when we're talking to a client who is experiencing behaviors in the home, the number one thing I always come into sessions with is a trauma-informed approach to care. Behaviors can bring up so much in the caregiver and the person we're working with that we don't even know. And before I'm starting to go through strategies, like we talk a lot about boundaries and self-care and all of that, we have to make sure that our client is safe. We have to make sure that our client is feeling safe and that they have the appropriate skills and resources so that if they are experiencing a trauma response, they're going through what they need to go through first with that before we're now, applying those other techniques that we might with a caregiver. I've had clients come to me honestly and tell me that as a result of behaviors, previous trauma in their life is exacerbated. We don't know what the relationship is like between the caregiver and the person they care for, and add behaviors on top of that, and we don't know what it's bringing up for them. Or maybe it's not that specific relationship. Maybe they've had some sort of abuse or triggers or traumas from a completely unrelated relationship, and it's being brought up with behaviors. Now, what do I mean when I say behaviors? Well, BVFTD can present with a number of behaviors, but some of them can be, verbal lashing out, insults, yelling, screaming, physical hitting, kicking, punching walls, punching objects. And for someone who's had a history of some sort of trauma, it can bring up a lot for them. I've also heard of people who have gone through trauma that were not related to, caring for somebody in the past, like even a genocide or a war, and behaviors can bring that up for them too. So when we're doing our assessment or we're starting to work with someone, when we hear behavior, and I'll talk about this more later when we go through case examples, we have to be mindful of the trauma first. We also know in research to be true that when behaviors come up with caregivers think that it's their fault and they take it on themselves to feel like they're the reason the behaviors are happening. So education again here is paramount, either by ourselves as clinicians, or if we're working with a team or we can employ another team member, having a behavior support specialist or someone else who can talk to the caregiver about why behaviors are happening or specific behavior approaches is key, because that way we can teach the caregiver that it's not necessarily them, that there is an illness going on and a diagnosis, and just because they're getting behaviors doesn't mean it's their fault. Because as we know, guilt and shame again is very high in caregiving as a whole, and behaviors can exacerbate this, especially if you're being told by the person you're caring for that you're a horrible person and that everything is your fault. You can only imagine what this is doing to guilt and shame. So those are things that I would really want to highlight with behaviors. We also want to make sure that we realize each person is very different. We are approaching the client where they're at, and we can't ever make assumptions. So if we think we know the client and we're going through our relationship with them, and then something comes up, or you're noticing they're starting to have panic attacks, or you're noticing that they're not able to sleep at night, or they're having nightmares, we have to use our clinical judgment and reasoning and our training to recognize there's something else going on. And then we might want to pause where we're at to tackle that, because it's our job to make sure that our clients are as safe as they can be, and also to identify what might be happening as a result of behaviors. So as I just said, trauma-informed approaches and remembering the whole person and the hidden person. Clients don't bring all of themselves to our sessions. As we know, sometimes they're too scared. They don't want to bring it forward. They might be worried that if they say something to us about the person they care for, they'll get in trouble. I'm a social worker, so people attach social worker with children's aid worker and think that we're going to take people away. And so, again, by building that positive therapeutic alliance and providing education to people and having a gentle approach to care, we can hopefully help people along. So if these things come up, we'll see them. But I'm always aware that I don't know the entire story, and I can't possibly know the entire story of the person in front of us. We also have to keep in mind, and I'm a very big attachment focused therapist, so I truly believe that what people are bringing into the session with me and what comes up as their caregiving is very related to attachment and how they were reared as a child and brought up. And what I've noticed in my clients 25 years and up is that there wasn't this societal approach and focus on emotions We know that very well. A lot of people don't know how to deal with emotions or even what emotions are being presented to them. They don't know that certain bodily sensations can be related to emotions, and they're seeing emotions as things that maybe they shouldn't have, right? A lot of people who were brought up, especially by people of the silent generation or even some of the baby boomers, were taught you don't have the feelings, stay in your lane. We hear all sorts of things, and that was just a product of society. It's not a blame on anybody, but we have to remember that this is how the person is coming in. So we can't assume anything, and we have to meet people where they're at. Okay, I talked a lot about guilt and shame, but I also want to talk about fault, guilt, and shame and behaviors again, because FTD behaviors can be tricky. I'm going to bring myself in here for a second. Um, Nothing that I did necessarily precipitated behaviors. I could walk in front of my mom and be told that I was a horrible person, and I could do something and be told that everything was my fault. And that's exactly how it was. It's not her fault that she said that, and I later realized it was because she had a diagnosis and something she couldn't control. But that's how it can feel to a caregiver. And they are very much internalizing and processing this is my fault, whether you're a partner of someone or it's your child or it's your parent or it's your friend. It's really awful to hear from somebody that these things are your fault, and it is normal to blame ourselves. So when they're coming up and saying I feel really bad, and we're trying to challenge that in session and say, oh, but that's not your fault, they won't believe us until we have the education to stand behind it or to actually enforce, well, this is how I know that this is from the illness. And that's why AFTD is an excellent resource, because they have a lot of worksheets, they have a lot of information on the website that we can use to validate our clients through the guilt, shame, and fault. But as I said before, shame can also come up from childhood. It's how some people were raised. It has positive effects in our society, right? We have to feel shame. We have to feel guilt. Otherwise, we might end up doing things that are going to lead us to prison. So there are a lot of ways that guilt and shame help us, but they don't help us in terms of these processes that are not typically what would be considered normal in terms of a brain degeneration in our society. I just talked about that. Okay. So when caregivers are burnt out and they feel completely overwhelmed. So once we've gone through all of the checklists in terms of trauma, we've done our assessment, we're knowing if there's behaviors or not, we might know what's going on. We want to start to employ some sort of technique with the caregivers so that they have more space, because we also know that when caregivers are burnt out, it's very hard to get out of that, but it's also really hard for them to provide care. And if we're looping in burnout with behaviors, or we're looping in burnout with grief, right? If someone has PPA and they're losing their words and this person is caring for them and they're trying to have a conversation and then the person they love can't speak, that's exacerbating grief and that's leading to further burnout. A lot of times when people are burnt out, they're trying to assert more control because they feel so much anxiety and they don't know what to do. And it's up to us as clinicians, and this is why therapy is so important, because we're helping people realize what is going on for them emotionally. We are helping people identify and realize where their emotions might be coming from, what might be leading to what, and what they can do with these emotions. Because I've seen as extreme examples of caregivers, hiding themselves in their home for 20 years, the duration of an entire illness, because they just couldn't deal with their feelings. And we're helping caregivers not only go through these very difficult circumstances and all the emotions, we're helping them learn how to live their life. We're helping them learn how to not lose themselves. And so it is also our role, if it's ongoing or even brief solution focused, to try and help caregivers figure out where they have some space so they can identify some of what they still enjoy. There's a lot of identity missing for caregivers. They lose who they are, they lose what they enjoy, they lose what's a part of them. And sometimes I'm working with caregivers after the fact, trying to remember who they were 15, 20 years ago. So we're helping them where they're at now to not lose that. And there are many ways that we can do that. But people get burnt out because they're pushing themselves aside. They're pushing aside their daily needs, both physically and socially. My father didn't talk to a single friend for 16 years because that was his focus, and he said, I'll deal with it later. And we know that that approach is actually that hinders the entire experience, but also he had to now reconnect with people 16 years after my mom passed and lost all of those connections. They're trying to balance other people and tasks, but often putting themselves aside and not dealing with their own selves. And they're not using external supports, or they don't have access to external supports. Or you might hear this, I hear this a lot. What could this possibly do for me? What could therapy possibly do for me? And so our role is to validate and say, I can't fix the situation for you. I can't fix the diagnosis. I can't fix what's going on. What I can do for you is be here, provide a safe space, be a listening ear, and try to see how we can make this even a bit better for you, make more space for you in this experience so that it's not feeling as intense and as hard, or when the behaviors come up, or when you see this person losing their language, as you go along with this, all the stages, I can be here for you if that's possible. It's also our job to liaise and provide resources to other supports if we can't. So when I worked in the hospital, it was very brief solution focused. I might have had 1 or 2 sessions with this person for 15 minutes. I couldn't do very much, right? Except for validate and provide empathy. But what I could do is provide resources like AFTD to say, listen, here's more supports that you can get after me, right? Not leaving them, because each stage is difficult in its own way, and each stage brings so much up, and we want to make sure they're being supported over time. The other thing I hear from caregivers is, well, I got therapy, or I saw somebody 2 times and now I'm good for the remainder of the illness. And it's great that they're feeling like they have the resources and the support in their toolbox for that moment in time. But as we know, things change, they decline, and it goes far along in different stages. So it's our role to also give them access to supports. So when we start to bring up boundary work and self-care and all of that, I find this is where emotions become really heightened. People experience guilt and shame on a good day. I've said that already. When we start to tell people, you know what, take 5 minutes for that cup of coffee in the morning, like very small things, or take that walk for yourself because you have to care for yourself. A lot of people are inundated with thoughts of guilt and shame. They don't know where that's coming from, and a lot of times they can't even identify what those things are. And so I always say that a lot of the emotions to do with caregiving aren't even related to the caregiving. It's everything underneath it. It's beliefs about self. And something I love about ACT is that it involves self-compassion. Kristen Neff is also an amazing researcher in self-compassion. And so at this point, when we're talking about where the emotions are coming from, again, we're educating on these things are actually from underneath. These things are coming from somewhere else. And we might be looking more deeply at where these things are coming from. But also, we have to be mindful of not going from 0 to 100 when we're proposing boundaries or saying go on a trip or do these things. Those are really hard for caregivers, not only physically, not only in terms of getting respite, but also in terms of what is coming up for them emotionally. Because a lot of people will say, well, I had this moment. I had someone come over, I took half an hour, and all I thought about was the person I care for. And I couldn't focus, I couldn't enjoy, and I just came home. And so in session, we're actually saying, okay, so what do you think was going on for you? And they'll say, well, I was worried. Okay, but that's also guilt, right? You're taking space for yourself. That's guilt. So what is that guilt saying to you? Where is it coming from? And how can we start to make small moments for the guilt, if we're starting from 0, to allow yourself to see that the guilt isn't hurting you, right? And we know from evidence and literature that the more we expose ourselves to an emotion when done safely, and of course, using our therapeutic approaches, the quieter the emotion can get over time. If we know what the emotion is, it's not going to hurt us, and that it might pass us over like a wave or a cloud. It has its peak and it has its valleys. And that's something that ACT uses a lot too. So I feel like we're problem solvers. We're always fixing puzzles. We're trying to figure out where things are coming from, meeting people where they're at. It's not one size fits all. And I think that's where the case examples are really, really great, because we're able to see that each scenario is different and how we employ some of these practices are going to be different for every single person. So let's get started with the case scenarios because I think this is where we take all of the information I just provided to you and put it all together. So I have 3 case examples and we'll see how many we can get through. I think we'll be able to get through all 3. But this first one, we have a 25-year-old female living with her mom who has BVFTD. She's balancing a full-time job. Her parents are divorced, and so she's navigating that, and she's wanting to move forward in her life. So as a social worker, and many of us, we do a very thorough biopsychosocial assessment. In private practice, I'm spending sometimes an entire session doing this because there are many pieces here, and I need to know where I'm starting first and what's safe for the client before I move into deeper things. So I'm pulling out the primary issues. I can see that the mom has behaviors because she's told me it's BVFTD. So I want to know what the behaviors look like, how it's presenting to the client, also what her relationship was like with her mom, because if she had a relationship with her mom that was nurturing and loving, and suddenly there are a lot of behaviors and she's being told negative things, or even there's physical behaviors, I'm now focused also on how has this changed her dynamic? Is she going through grief because she's grieving what the relationship was and what it is now? Does she understand what BVFTD is? As we know, a lot of times people are going through the neurology office and it's here's the diagnosis, see you in 6 months, see you in a year. But does she know what we're talking about here? Does she know what it means? I've had people before in sessions say, yeah, this person has this diagnosis, but yet they're doing this. And they don't realize that the diagnosis is actually leading to some of what they're seeing. So we also have to figure that piece out. We know that she's dealing with a divorce, so her entire life is on its head because now her parents are getting divorced. So is she living alone with her mom and her dad, or her mom, or whoever the partner was is out of the house? Is everything on her? Who's in her social network? Who is her support? And she's saying she wants to move forward in life. So I'm looking through all of these pieces and I want to know about the behaviors. I want to know about any potential trauma. I want to know if she's seen a clinician in the past. Does she have any resources in her toolkit? Can she ground herself? Does she get dissociated? Is there anything going on in relation to the behaviors? Is she safe? Does she have a place she can go if she needs to be safe? And then once I figure all of this out, so with this person in particular, we find out that she has seen a clinician in the past. She's really great with emotions. She journals regularly. She's not afraid to have the emotions. And what she's really looking for is a way to try and find balance because she's losing herself. So once I know that she's safe and we're not dealing with this potential trauma, then I'm bringing in elements of self-compassion, right? Be kind to yourself, be gentle with yourself as you go through this. This is really, really hard. And I'm trying to see where she has space and all of the things that she enjoys to continue to keep up with in her life. She is telling me that she's getting calls around the clock from her mom and other family members. And so we're learning how we can start to approach what's a crisis, what's not a crisis, what she really needs to do in her daily life versus what's not as important, trying to say no to people. All of that is incorporated here, and then seeing what emotions might come up over time. And again, this is an overall therapy approach. If we're looking at long-term therapy, it would look very different if I'm doing brief solution focused. We won't have time for anything except for the validation and maybe giving some tools and resources. Okay, so in this one, we have a 50-year-old father who is caring for his spouse with PPA and managing 2 large businesses with his spouse. He has no external family support and significant family trauma. So again, I'm doing my assessment, and what's very clear to me here is the grief that is involved with somebody losing language, such as a spouse, right? They have a relationship together. They are managing 2 businesses, and suddenly all of this is falling on this person. Again, do they know about the diagnosis? Do they know what might be happening? And how is that impacting him? He's also saying that there's no external family support. So I'm looking at who else is in the network. There's something amazing called Atlas of Caregiving, and it's an approach to use with caregivers. It's free, it's nonprofit, it's online, where they can look beyond the typical what do we think of as family support and see who else is in our network that we can tap into. So that could be anybody like a neighbor, it could be somebody we forgot existed that lives an hour away. But I'm working with this person to identify that they also probably have a lot more than they realize, because not having family support can lead to additional isolation and loneliness and more emotions. He's also told me he has significant family trauma. So again, we're bringing in that trauma-informed lens. With this client, he is dissociating and having a very difficult time regulating his nervous system. So we're employing some DBT strategies, which I haven't talked about yet, dialectical behavior therapy strategies. As you can see, I pull from a lot of different modalities with my clients, depending where they're at. And again, this will depend in what sort of setting you're able to practice. But with him, how can we regulate? Do we need some space? Are we using cold water? Are we using ice? Is there something that we can do to regulate the nervous system using DBT approaches? And then we're dealing with the overall issue and the overall emotions. So with him, we had a very different approach than with the other person who was very familiar with emotions, very comfortable, not dissociating, and everything seemed to be more okay from the emotional standpoint in terms of recognition. We're working more on, okay, how do we find balance? That's going to come a lot later for this person because he's dealing with a lot of forward facing significant emotions and trauma. And then our last case example is a 75-year-old mother whose son is exhibiting symptoms that may be in line with FTD, but she doesn't know yet. And so investigations are ongoing, and there's no concrete diagnosis, but she is really struggling, and no one else can see what she can. So if we remember earlier on, when we talked about how sometimes it can be very isolating earlier on when you're seeing something but nobody else is. For this mother, everything is going backwards, right? Because the line of thinking in society is, okay, so I've taken care of my child, they've grown up, they've moved out of the home, and now that's where it ends. But now this mother is suddenly realizing I have to get involved again in care, but nobody else is seeing this. What is happening to my child? And I'm alone in this. I'm feeling this extreme life and dynamic change that's going on its head. So in this circumstance, my approach might be to name what that is first and talk about the dynamic change, to talk about supports and resources and who's out there, and to be a source of validation, empathy, and support in the sessions because this person has nobody else. She's also at a very different stage of her life than maybe she was when she took care of him in the home. And so where is she at? What are her limitations? What can she do here? Who can she tap into? She identifies that she's feeling trapped and isolated. So we're also talking about that. She has thoughts that she wants to just die, which we do hear that often too in clinical practice. And we're looking to identify, is there a plan? Do we need to employ some sort of safety technique? Or is this something that she's saying is result of feeling isolated and trapped because of the circumstance? And with her, there is no safety issue. She is just identifying feeling trapped as part of the illness. And the 75-year-old has never learned emotions. She doesn't know emotions. She doesn't know what emotions she's dealing with. And I see this a lot with my older clients. I've helped clients up to 95 years of age come to me and say, I've never identified an emotion in my life. And we're helping them try to figure out where they're at with their emotions, how emotions are connected to their body, doing that ACT work. So with her, we're starting from the beginning. And again, it's meeting the client where they're at and what they're going through. Every FTD experience is going to be different. No two are going to be the same, and nobody's individual circumstance is going to be the same. And so again, we're doing our due diligence as clinicians to meet people where they're at. I wanted to share this with you as we wrap this up and go into Q&A. So something that our practice is starting to do is actually introduce in-depth clinician training. So I did a very surface level today. I didn't talk of the details about the techniques and how I would necessarily put them into practice. And I've teamed up with two other clinicians in the States to provide a really new, excellent webinar and training that we're giving in the new year. And each therapist that is speaking is going to be talking about different aspects of caregiving and different modalities you can employ. And in-depth detail about how you can bring that into practice. So one of the clinicians, Dr. Barry Jacobs, who's a well-known caregiver psychologist in the States, is talking about relationship breaks and what can happen when someone in a relationship is caring for another person or caring for the person they care for. Another clinician is talking solely about grief in caregiving in much depth. And I will be talking a lot about ACT, which I talked about today, and how I bring it into practice with caregivers. So if you're interested in joining the waitlist, we will be releasing information on how to sign up probably mid-December. You can go to our website. It will also be shared through AFTD after this presentation. It's compassionandcaregiving.com/waitlist, and you can add your name and be the first to sign up. Spots will be limited, so that will be your opportunity to get your name in the door first. And I think now we're on to Q&A. I know I threw a lot at you, so maybe there's a lot of questions, but now on to Q&A.
Oh, thank you so much, Stephanie, for this presentation. I know I learned a lot, and you really have covered so many important experiences that people have with FTD caregiving in a short period of time. So it's really wonderful to hear about the in-depth training that'll be an option as well. So I know people's wheels might still be turning from everything that we covered. But if you still have not yet submitted questions, please do so, and you can post anonymously by checking the box next to the send button. But I do have a few questions that came in during the presentation, so we'll get started.
Great.
So I know we did also have some allied health professionals with us today that may be interacting with FTD care partners in other parts of their care. Do you have any suggestions for how they may be able to help refer or encourage caregivers to connect with therapy?
Yeah, that's a really good question. So I think AFT again is an amazing resource because we're coming from all parts of the world probably here. And so one size does not fits all. So I would say AFTD is a really good place to start in terms of what the resources are available. I know that we've talked offline and you guys have a lot of the knowledge of where they might be able to go. I think also if there's no FTD specific therapist in your area, it's looking at caregivers or what might be underneath the caregiving. It might not be as comprehensive, but for example, boundaries or self-care or guilt, grief, shame, all the things that I talked about today are really good ways to look at a therapist. So if you go to Psychology Today, and you type in those keywords, hopefully you'll be able to be connected to somebody who maybe isn't caregiver specific or FTD specific, but would understand nuances of the experience.
Great, thank you. Yeah, absolutely. Yeah, the helpline is that resource, for health professionals too, when you're looking for those referrals, and how to support the families that you're working with. Another question that we got was about male caregivers. Do you find that male caregivers are more likely to try and go it alone, maybe more resistant to having therapy or even attending a support group? Do you have any insight into approaches there?
Yeah, so what I do see is that that's absolutely accurate. I think there is a significant stigma in our society, especially with older caregivers, to go through it alone or that you have to be strong as a male and you can't, talk about your emotions. And in private practice, I do see the clients that are coming to me asking for support, but I will say that it's very heavy on the female. I think maybe 10% are male, which is much higher than it used to be. And I think that's just a matter of how our society is changing in terms of how we see mental health. But in a hospital setting, for sure, males were more reluctant. Males didn't feel like they needed that help and that therapy. We can't necessarily tell them what to do or push them in a specific way if they don't want to. Of course, they can make their own decisions, but we can lightly guide them, right? We can say, we see this going on. I don't know if you actually know this, but Therapy can help with you in these ways. It's confidential. A lot of what they're worried about is seeming that they're not actually strong or feeling like, they're going to be playing into the stigma. And so giving them education on emotions and that emotions are actually normal and normal part of the process might help. But I do find males who are resistant tend to continue to be resistant unless there's some sort of a crisis or they hit a breaking point or they can't function. A lot of them will try to continue just because of what they've learned over time. And it is changing though. I am seeing it change. But we can just educate on that emotions are actually normal for everybody, right?
Mhm. Yeah, absolutely. That's great. And I will say too, that at AFTD we do have a national Zoom support group that's specifically for male caregivers, is a resource as well. Yeah, but that's really great. Thank you.
Yeah, of course.
Um, and another question we have, or actually maybe very quickly, someone had just asked for you to review what ACTS stands for again.
Oh, that's a real, did I? Oh, sorry if I didn't. So
Yeah.
ACT, ACT is acceptance and commitment therapy. Um, I'm sorry if I just said the acronym. So it's
That's
ACT.
great. Wonderful.
Good
All right.
question.
Yeah. Another question we have is, unfortunately, we know that for some caregivers, they may be coping with this being a genetic form of FTD, which can have implications for themselves, other family members, and even generational trauma. Do you have any, thoughts on supporting caregivers in these situations?
Yeah, so I have in the past, and I think a big thing that comes up is should I be tested for, genetically? I would always recommend seeking a genetic support or somebody who's able to go through that with them because that obviously will inform the outcome and what comes after that. But this is a really hard one. It's something that's out of the client's control. It feels very unaware and seeing what someone else is going through in their life could possibly be them also. Um, in this way, I think when we're approaching things that are out of control, I would use part of acceptance and commitment therapy and looking at what we know now to be true, what thoughts and emotions are coming in. If things are out of our control, what do we know to be in our control? Using mindfulness techniques to bring us back to now. And even some cognitive behavioral therapy techniques can help challenge anxious thoughts. But there are very real aspects of not knowing whether something is going to be genetic and hit us, what decisions to make. And so I always employ, practices of working in an interprofessional team, right? We can't do things in silo as practitioners, and we have to call upon other people who might have further knowledge and information in this. And so I look to my genetic experts when it comes to that.
Yeah, that's great. Yeah. And so another resource to share with that is that AFTD does have two specialized support groups for those with facing familial FTD. And the helpline can definitely share more information about those too. And that, may segue into what might be our final question. You've talked about therapy, but also the other supports, yeah, working with an interdisciplinary team or maybe peer support in a support group. Are there other supports or resources that you recommend to help, put into that support plan for the care partner?
Yeah, so one thing that's coming up a lot these days is, I'm alone, I don't have friends, I don't have supports, I don't have access to these things that I want. And something that is happening more and more is actually the use of social media to try and connect with others. There are a lot of pages or groups out there where you can actually meet with people from all across the world going through similar things. A lot of people I've worked with have found great comfort in that, even by not, they don't want to contribute, but they're just sitting on these forums and watching and seeing and noticing, oh my gosh, that person is going through what I'm going through, and I didn't even realize it. Podcasts can also be really helpful if this person doesn't want to get involved in support groups or therapy, but they want to feel validated and know that their experience is not alone. There are some really great FTD podcasts out there. You can just search FTD or caregiver, looking at your podcast. A lot share stories about caregiver experiences, and you'll probably be able to relate as a client or as the caregiver to other stories, which can provide great comfort. I definitely did that myself too, and I work in this space. So that's really helpful. And there's out of the box therapies and groups that may not necessarily be, therapy based in the terms that we think of mental health therapy. But I have clients who love art therapies. There are some amazing art groups that are provided, I think, by Rare Disease Canada, because I'm in Canada, but there's other ones and they're virtual and they found them to be phenomenal. Any sort of creative approach. Some people do equine therapies, so horse therapies. So there's a lot of out of the box things out there, and it doesn't have to be FTD specific, but if we're looking at what's underneath all of it, we can apply some of that to our approaches.
Yeah, that's wonderful. Thank you.
No problem.
Yeah. So I think that that is probably the last question we have time for, but I have a few other things to share with our audience as we wrap up for today. And thank you so much, Stephanie. If you still have a question today about FTD, you are always welcome to reach out to us here on the AFTD helpline by our phone number or email. And we're always available for care partners as well as health professionals. And finally, we are excited to share the details of our next webinar, FTD Research 2025, Paving the Path Towards Effective Treatments, on December 10th from 3 to 4 p.m. Eastern, and we hope you can join us. And again, please let us know if you have any comments or questions about today's presentation, and a reminder to look for an email tomorrow containing instructions for submitting your CEC credit. And this concludes our webinar. Thank you for joining us.